Are you guys ready for a day in the life of a Psych NP in private practice? Well, stay tuned. Welcome back, Psych Dude family. It's good seeing each and every one of you guys today. If you are new to this channel, let me formally introduce myself. I'm the Psych Dude. I'm a board-certified psychiatric mental health nurse practitioner, and in this channel, I go over several different subjects to educate the public about mental health, ways to improve your lifestyle, topics related to nursing, nurse practitioners, and specifically psychiatric nurse practitioners like myself. So if you're interested in any of these topics, feel free to subscribe. Make sure you like this video and follow me on Instagram at THEPSYCHDUDE. So you probably clicked this video because you're interested in finding out what it is like in a day in the life of a Psych NP in private practice. Yes, I made a video previously in a day in the life of a Psych NP, but that was in a community mental health setting, and private practice is a little bit different. Yeah, it's one of those things where it is a little bit more fast-paced. It's one of those things where patients are, I'm not going to say a lot more stable, but they're stable enough to be able to graduate from that level into a lower acuity level, but sometimes we do see some higher acuity patients, and sometimes we have to refer out to some of these settings in order for them to get the best care that they can. Typically in private practices, you're kind of limited in the sense of not necessarily having all of those resources like case management, like social workers, things like that. Some places will have that, but in my private practice, we don't necessarily have that. All we have are psychologists, we have psychiatrists, we have nurse practitioners, and LMFTs. So without further ado, let's get started on a day in the life of a Psych NP in private practice. So stay tuned. Alrighty guys, so I just got into the office, and the very first thing that I do is make sure I go to my folder and check all the paperwork that I have to either fill out or I have to complete. And this is the amount. The reason why it's so thick is because I'm only here once a week, and then also I was gone for the past week because I was in Hawaii. So it's a huge amount of paperwork. So paperwork can consist of refilling refills, prior authorizations, filling out paperwork on behalf of patients like FMLA, things like that, and then also just the assorted amount of paperwork. So sometimes in private practice you have to deal with this because you don't have the resources compared to other people or other places. So it's definitely something you have to consider when working in private practice. Also, you want to make sure you look at the list of patients you have and see how many patients you have on your load. When I looked at my patient list, I saw that I had 20 patients today. It's a mixture of follow-ups and new evaluations. If you're not familiar with follow-ups, typically they range from 15 minutes to 30 minutes, and you're following up with patients that you've already seen and you've done the initial evaluation for. And for my initial evaluations, they go from 30 minutes to an hour depending on the patient and if you've screened them before. Typically it's an hour, but in this setting it goes from 30 minutes to 45 minutes, and it's relatively fast because they're, like I said before, the acuity levels aren't as high. Typically I try to stay within the 45 minutes to an hour, but it just depends on your availability, and sometimes since I'm only here once a week, then my availability isn't as high, so that's something you have to consider. But unfortunately in the private practice setting, no-shows are high, and unfortunately that's something that we have to consider, and you must consider if you want to work in private practice. Alrighty guys, so my very first patient did not show up, but since I have a huge stack of paperwork, might as well continue and finish that off. Also, one thing, when you are filling out these refill request forms, you always want to make sure you look inside the chart to see if they actually ran out of the medication, because sometimes they might just go to the pharmacy and let them know, oh, I ran out, and then sometimes the pharmacist will just send in the request. So you want to make sure you check in the system, and then make sure you check certain medications, because certain medications you can't just start off right away. If they've been out of the medications for a period of time, you can't just start off at that dose. Specifically, Lamictal is one of them. You can't just start if they ran out, been out of the medication for like 2 weeks. You can't start them off on the same dose. You have to titrate really. You have to go slow or low, and then you have to titrate up slowly. So say for example they're on Lamictal 200 milligrams. If they're on Lamictal 200 milligrams and they've been out of the medication for 2 weeks, you have to start back off at 25 milligrams and then titrate up slowly in order for them to reach that therapeutic dose. And sometimes it sucks because you have to go so slow just to avoid Stevens-Johnson syndrome. So if you don't know what that is, look it up and you'll be horrified. And if you can't tell already, there is so much more paperwork when it comes to private practice, just because, yeah, there's just so much more paperwork because one, you see more patients, and two, a lot of these patients, since they are higher functioning, in case they can't make appointments, you have to be able to give those refills, or you have to be able to provide them with paperwork depending on what's going on. For some children, sometimes they want reports, and for some adults, if they've been on FMLA, you have to turn in paperwork justifying why they're on FMLA, give them your diagnosis. So much more paperwork, and like I said, if you don't really necessarily like that stuff, then you might have to consider if private practice is right for you. And also, since I have free time, might as well take you around and give you a tour of my actual office space. So let's go. Yeah, so this is my office. I hope you guys like it. So, just saw my first patient. The good thing about this patient, it was a follow-up, and the patient is doing well and is stable. Depending on how stable your patients are, sometimes you can go beyond the 1 or 2 months follow-up, and you can go to 3 months depending on how stable they are. That's technically my furthest I'll go out is 3 months. I know some providers will go 6 months or even longer, but for me, I like to be on the safe side, so I like to see them at least every 3 months if they're stable. But like I said, it just depends on the person. Patient was doing stable, was only on 1 medication, doing well, sleep was good, appetite was good, not having any side effects or issues with the medication. So I went ahead and gave her a 90-day supply so I can see her again in 3 months. So one thing's important to add is that sometimes depending on the patient, if they are on a controlled substance, you want to be able to check cures. So for us in California, we check cures, and that's pretty much our system to be able to see if they're on controlled substances. If you are prescribing controlled substance, you want to be able to make sure that they're not getting it from another provider, or you're not getting another controlled substance from another provider that might be contraindicated amongst the two. So it's definitely important. You want to always check that, regardless of if they're a new patient or if they're a follow-up. For me, for every single initial, I make sure I check that just so I know what I'm going into. It's a beautiful tool that you should use in private practice or anywhere you go, just to be able to make sure that they're saying they're on the same meds. Sometimes I've had patients where they come in, they've never said they have no substance abuse, they have no issues with medications, they're not taking any medications, but when I check the system, it shows they're on like Suboxone, they have like 2 milligrams of Klonopin 3 times a day, things like that. And you want to make sure you check this, because it's just gonna pretty much CYA. It's gonna cover your butt, and it's gonna be able to give you some help in regards to if they've been on these type of medications. And also for the ones that come in on ADHD medications, if they're saying, oh, I've been on this medication, it's another way for you to verify. Unfortunately, it's pretty much statewide, so your states might differ. For me, it's called Cures. For you guys, I'm not sure if you're in another state, but comment down below if you are in another state and you know the name, and just so I can do more research on it too. Alrighty guys, so it's finally lunchtime. I've seen 10 patients so far, and I do give myself 30 minutes for lunch. So I'm just gonna hang out, sit back, and just enjoy the time I have off until my next patient. So enjoy. Alrighty guys, so I just got done doing an initial evaluation. This one wasn't that bad. It was relatively simple. Well, I can't say it's relatively simple. It's one of those patients where this is their first onset of depression, and they were trying to cope with it through therapy, and then now the therapist referred them to me. I'm not going to go in details because I want to be HIPAA compliant, but I just wanted to go over what is involved in initial evaluation, because that's important to understand, especially when you're in our, pretty much, if you're interested in working private practice or just working as a psych NP or psychiatrist or a psych PA, you want to be able to understand which components you have and understand which components you need when you are working in private practice in the outpatient setting. So you always want to have the ID. You want to make sure you ID the patient. You want to put in their chief complaint, and in their words, what their chief complaint is. And then from there, you go to subjective, is where you do your HPI. So you want to do your history of present illness, and you want to be able to understand and be able to put into writing, paint a picture of what is going on in their life and how the symptoms are affecting their life and which symptoms they have. From there, you want to be able to go to the past psychiatric history. So within past psychiatric history, you want to be able to put what their prior psychiatric diagnoses are, their inpatient hospitalization, outpatient treatment, if they had any suicide attempts, if they had any self-inflicted, self-injurious behaviors, if they have history of abuse, and then you want to put their current psychiatric medications if they're on any, and then you want to put the previous medication trials. So put the previous medications they've been on, their reaction to it, if it was successful, if it was not successful. You want to ask the doses and what actually is the reason why they switched out of it or off of it. And then from there, you go to their past medical history. It's important that you get your past medical history and being able to identify what their current medical problems are. If they have any history of seizures or history of LOCs or head injuries, you want to be able to document what their current medications are. And then if they have any surgeries in the past, you want to be able to document that, or any medical history, you want to be able to document that. In this section, I do like to document if they have any allergies, who their primary care doctor is, when was the last time they had a wellness exam, when was the last time they had a set of labs done, and things like that. And then for females, obviously you want to ask if they're sexually active, when their last menstrual period is, what type of contraception they use, if they're sexually active, and if they're breastfeeding. These things are important to ask because you never know, especially when you're having this conversation, they might be late on their menstrual period, and that's something you always have to consider before starting medications, because some of the medications we prescribe can be contraindicated. So from there, you want to be able to come across their substance use. You want to be able to document if they use substances, if they abuse it, and you want to be able to understand what it's like, because a lot of the times people will withhold information. So it's for you to kind of get that information out of there. And then from there, you go to ROS and then just be able to document if anything's going on medically, right? And then after that, you want to be able to document the social history. For me, social history is a good thing because I like to understand all of these things, like where were they born and raised, their highest level of education, what do they do for a living, what are their interests, hobbies, are their parents still together, were they going about that, were they divorced, were you adopted, do you have any children, are you married, things like that. You want to be able to understand where do they live, what's their living situation, if they have access to weapons. You want to always make sure you ask that. And then growing up, what were their milestones? And then from there you go to the legal history and you ask if they have any current legal issues, or if they've been arrested in the past, if they've been on probation, things like that. And you want to be able to understand all of those and paint a picture, because you never know if you're going to continue with this patient. At least the next provider will be able to have this information, and then if you do follow-ups, you can have this information also. And then from there you do your MSC. If you haven't already understood MSC, make sure you look that up, because that's important, like I said before. And then you go to your assessment. So you want to be able to document what your diagnosis is, and then from there you want to be able to have rule outs. I always like putting rule out diagnosis just so I can understand maybe they might be bipolar, or if they might just have a mood disorder, or if they just have depression, anxiety, things like that. If you suspect something, just pull it in the rule out and be able to come back to it later on. You don't have to give a firm diagnosis the very first time, and you don't have to prescribe the very first time. You have to do what you're comfortable with and what you feel is within your scope, and then you can always do a follow-up to the initial and then prescribe that time. So it's totally up to you. You want to, and I forgot, in the history of present illness, you want to be able to do your suicide risk assessment. See if they have any SI, HI, if they feel like they want to hurt themselves. And like I said, they already talked about prior history of suicide attempts or self-injurious behaviors. So you want to do a suicide risk assessment in the assessment, and being able to see if what their suicide risk is, what their protective factors are, and their risk factors. And then from there you want to come up with your plan on what you want to do going forward, what your plan is, and which medications you're prescribing, which ones the safety plan, what your treatment plan is, and all of those things, and what you educated. And yeah, pretty much that's the gist of it for the initial evaluation. Like I said, the biggest thing is you want to document as much as possible, but obviously you want to document accurately. And sometimes people document way too much, and some people document way too little. So you kind of want to be in between. But like I said, you're the one following up with the patient. You're the one who's going to be able to continue their care. So for me, I like to document appropriately, accurately, and not too much but not too little, just so I can have a painted picture in front of me. So going forward, if I don't come up with the right medication the first time, I know what I can do going forward, and this helps me when I do provide that supportive therapy. So yeah guys, sometimes it's one of those things where sometimes I like to sit behind the desk, and sometimes I like to sit in that chair. It's one of those things depending on how I'm feeling. And sometimes when you get to know your patients, sometimes they feel more comfortable with being closer to you, and sometimes they feel comfortable with you being further away from you. So you kind of have to gauge that. In initial evaluations, typically I like to stay a little bit further, and then as I get to know them, depending on the patient, if they request to be seen closer, then I'll be able to sit in that chair, or I'll pull up a chair for them to sit closer. Because let's face it guys, patients like some intimacy, especially when they're talking about themselves and they don't want to be so far. But at the same time, you need to be able to create boundaries for these patients, because sometimes they don't have boundaries, and it's for you to actually set them and be firm with them. Alright guys, exhausting day. Finally done. So I saw 16 patients. I had 4 no-shows. So I had 4 initial evaluations and the rest follow-ups. And I'm happy with today. I think today went relatively well. No stressful situations, and yeah, pretty not necessarily easy, but not as crazy as it can be. And some days in private practice it can be super crazy, and some days it can be super mellow. This day was one of those in between, where I had some serious moments and then some moments where it's not too bad. Yes, I'm thankful for some no-shows. I know some people say like, I wish I had no no-shows, but sometimes these no-shows just kind of help me catch up, especially when documenting and being able to see so many patients. Sometimes 20 is a lot for people, but sometimes 20 is a little. It just depends on your level of comfortability. So the good thing about this private practice is I get to set how much time I get with each patient, and sometimes I like to do pretty fast and sometimes I do really slow depending on the patient. And I do like to set out a longer period of time for elderly because sometimes you're the only person that they talk to depending on what's going on, and they just love that. So I do set some time, longer periods of follow-ups for them. But yeah, I hope you guys enjoyed this video. I hope you guys learned something today. If you have any questions or concerns, please comment down below. As always, have a wonderful day. Bye.